All right, we're going to look at a pretty great article here. The purpose of the video is so that way I can highlight some of the things to make it easier for you to read and faster to digest. This is a medical team based out of Boston looking at accuracy of physical examination tests for the diagnosis of mid and low lumbar nerve root impingement. Sometimes it's not necessarily important that if you know exactly which level, but is it mid or lower? That's what they were looking at here. So I highlighted some things we want to make sure we hit. So the classic presentation of radicular pain in mid-lumbar nerve root impingement is the groin or anterior thigh, but what the point that they're going to show here is that it can sometimes go distally to that as well, and we'll hit some of the tables of that, and which can mimic a lot of other clinical presentations such as hip arthritis. And that's definitely why we have to be so detailed with these tests, so we can identify clinically where the what's primarily going on, especially if they have concomitant hip arthritis and nerve root impingement. You know, which one is the primary driver of the symptoms if we can determine that one is more so than the other. So this next paragraph was really great. So it talks about prior studies have examined performance of a number of these things, but they haven't delineated between mid and lower. And that's a good point, is that sometimes we just need to know, okay, it's right here. And it may not matter if it's right above L3 or right below L3, right? You know, that's the area that we need to be looking at and that there is an issue. Unless we're doing surgery, it doesn't matter exactly which level it is, but that we start targeting our treatments near the right area. Because any type of conservative treatments are going to be a little bit of above or below. We'll have some ripple effects there. And also is that some of the other data is that they were just for disc herniations, where there's a number of other ways that you can have radicular pain. And so we needed to see just where's the nerve root impingement and not just focus on disc herniations there. This one they also use, which we haven't gone over yet, is the straight leg test and femoral stretch test, femoral nerve stretch test. And those are typically not specific for a specific nerve root, but overall sensitivity. And not enough research has been done on the femoral stretch test, and so they did look at that here as well. And they looked basically, one knows at mid lumbar, lower lumbar, and then they did look at level specific roots as well. And all these people had lower extremity radiating pain for less than 12 weeks. So they did straight leg raise test, femoral stretch test, and they did knee extensor strength. So they did a single leg sit to stand. They did a heel walk test for the ankle dorsiflexor, ankle plantar flexor strength. They did single leg heel raise, up to 10 of them. And they also did dorsiflexes the great toe, and hip abductor strength. All of these, it was a dichotomous outcome, yay or nay. Could they do it or could they not? So like heel raise, could they do 10 or not? There wasn't any gray area. They also did some sensory testing and reflex testing. Notice on all of these, there's no touching the person's back, which can be helpful as well if we're trying to determine if it is from the back or not. And they also, sometimes when we do motor testing, if you may get some weakness, but they may be able to pass a baseline. So sometimes they may be able to do, like, say 10 heel raises, but if one side could do 20, the other side only 11, that would be a difference. And they didn't categorize that here in this study, which is difficult in research studies. It's easier to have cutoffs for sure. So it is understandable, but a little bit differently than what we do in standard practice. Talks about the statistical analysis and all the results here. One thing was, it said that a combination of the tests didn't change the likelihood ratios because of changing sensitivity and specificity. What it goes to show is that there's lots of ways to look at data, and we have to look at it with everything. This isn't the only things that we're going to be doing in an examination. is just the dichotomous outcomes of these specific tests, but we're going to be looking at history. They did a little bit here, remember, with inclusion-exclusion criteria, but we're also going to look at nuances like, was it a little bit weaker on one side versus another versus just a yay or nay. And so we're going to scroll down here. We're going to see all their references. So the single-legged sit to stand. They could use their hands a little bit, just out of a chair. And now we're going to, let me flip this. Ah, very good. So when you're looking at where the symptoms are, that is really good data. Where you would expect it to be, it often is. But also remember that sometimes it may be in a little bit different spot. So L2 symptoms, so let's just take a look at L2 symptoms. There was only two of them, but they both had anterior thigh pain. One of them also had groin pain. When you look at L3 symptoms, a little bit in the groin, but that's higher than you would expect. And then all of them had anterior thigh symptoms. A little bit of lateral symptoms as well. And then knee is anterior knee, but never posterior. And then calf, the anterior calf at L3, it was down that far for L3. Now remember, why would that be? That's different than what normal dermatomes that we learned. Just because so there could also it could be sensitized just from the nerve root below. Why is that? We don't exactly know, or maybe it's just a peripheral sensitization. They've had it 12 weeks or less, and so you don't get as much peripheral sensitization, but you do get some. L4, it's where you would expect it to be. Lateral thigh, maybe a little bit anterior, so it's going to be less often there. And oftentimes it does, it can sharpen up down lower where you notice that anterior and medial and lateral, it's a little bit of all of them, but more anterolateral, which is more common with L4, L5. And then we look at the L5, it loses the medial, still a little bit anterior, but then much more lateral and posterior. So you could see how it moves along our normally defined dermatomes with some smudging there. And then S1, where is it mostly posterior with a little bit of lateral, and it completely loses its anterior. And so we could see that they do follow normal patterns with a little bit of variation. And then the thigh, posterior, never anterior, a little bit lateral. And so you can see also up there with the thigh that it's moving as you would expect it to. And then as we look at a lot of the other tests, a lot of them, some are better than others. Some of it depends on how they classify it, remember. And this one they're looking at mid versus lower lumbar. We don't need to delve into all the details here. The sit to stand test is a very good one. It's different than what I typically teach with quadricep testing manually, but if that's negative, then I will move to something like this if nothing else is sticking out. The problem, I would say, with this one is that it's also positive in a number of other people besides just that. And there's also reasons that you could have a quad weakness outside of radiculopathy, but that could also go for just when we're manually testing it. So again, we have to take it in context of their whole history. But these are people that have radiating symptoms less than 12 weeks. So it's closer to that acute pain. Some of those could be subacute there. And then sensory testing. Sensory testing lines up pretty well with where their symptoms are. And this one is, you can't see that one very well. And so again, this is looking at the things like the femoral nerve stretch test, the straight leg raise test. And what are their contentions? The straight leg raise, we look at is their lumbar nerve root issue. That's mostly looking at L5S1 because it's looking at the sciatic nerve, where the femoral, and that could hit L4 as well, but the femoral nerve stretch test hits a little bit higher, and that does have a good positive likelihood ratio for L3. For L3, and if there is a femoral stretch test, then it's very good as well. And that's ones that we haven't gone over in the course, is those type of ones. But again, remember, these people didn't touch their back at all, which we didn't go over in the course. That's not part of the neurological exam, but is part of diagnosing whether it's a lumbar issue or not. And that's where they're going into with this: is it a lumbar issue or not? And these can be good tests if you want to go learn how to do those. It's not a bad thing either. I look at it as a little bit lower than the other ones because it's more regional than level specific. And that is the what we wanted to focus on for this article. Accuracy of the physical examination for the diagnosis of mid-lumbar and lower lumbar nerve root impingement. It was done in 2011 in the Spine Journal, which is an excellent journal. And the summary is that no one test is magical. You take them together, it doesn't actually change your likelihood ratios, but you do that with other things. Often, like the Hancock article showed, neurologists and so can all healthcare providers with detailed testing have a good idea of where the nerve root impingement is coming from.